This next section looks specifically at the one subject of microcytic anemia. How are we going to answer what is the most likely diagnosis when they all have the same smear and the same symptoms? What is unique about each one? The smear in microcytic anemia, these red cells are very hollow, very circular and ring-like. They shouldn't be that pale. The rim of hemoglobin should not be so thin. That's too pale in the center here. That is why all the smears of all the microcytics look the same. They look very hollow in the middle. Microcytosis, by definition, means simply an MCV that's less than 80. By far, the most common cause of iron deficiency is blood loss. Malabsorption is rare. Things like celiac disease can give a malabsorption, presents with a malabsorption of iron because of damage to duodenum. But it's far more common, of course, to have blood loss. People who menstruate a lot, people who simply have GI bleeding at various points. And that's because although you need only 2, 3, 4 milligrams a day of iron, you can't increase absorption that much. So if you lose as little as 1 teaspoon a day of blood, it leads to iron deficiency over time because although you may not need much iron, you may only need, well, a non-menstruating man only means 1 to 2 milligrams a day. If you're menstruating, it goes up a little bit, 2 or 3, and pregnant women can go up as much as 5 or 6. But you see, that's not a big range. It's kind of a tiny range. However, your ability to absorb things, the duodenum absorbs maximum 4 milligrams a day. We don't have a lot of variety there. So if you lose 1 or 2 teaspoons a day of blood in your stool, number one, you wouldn't notice it. It would come out as brown blood. You don't get melena. How much blood do you have to lose a day to get melena? Well, black stool doesn't start till you lose 100 ml. So you wouldn't even notice 5 or 10. You wouldn't notice 15 or 20. So therefore, all blood loss will eventually give you iron deficiency anemia. In the anemia of chronic disease, the MCV initially is normal, then it'll decrease. The anemia of chronic disease is just unknown. We don't know exactly what shuts down the marrow in chronic diseases like infections and cancer. We just don't know why it stops working. The clear mechanism is only in renal failure because of deficiency of erythropoietin. That's very straightforward. And hemoglobin synthesis just doesn't go forward. It doesn't occur because the iron doesn't move forward. The iron gets locked up in storage. Heme is not made because iron is locked in storage. It's trapped in the macrophages. It's trapped as ferritin. That's why the ferritin level stays normal or even goes up. That's why the iron binding capacity is down. The empty spots is down. It's locked in storage, but you can't make cells from it. Sideroblastic anemia is very unusual. It can be a macrocytic anemia when it's associated with myelodysplasia. It's most commonly from alcohol, not lead. Lead can do it. Less common is lead. Lead is the most common wrong answer. It just sticks out in people's mind. Lead is not the most common cause of sideroblastic anemia. There's not much lead out there in society. You can't go down the street and get a lead and tonic. You can't go get a case of lead at the supermarket. Isoniazid can do it, and there are some people who have a congenital B6 deficiency, aminolevulonic acid synthetase, ALA synthetase deficiency, and that small number of people, small variant, will respond to pyridoxine, which is vitamin B6. The majority of sideroblastic is alcohol. You have to stop the alcohol, and you will get an improvement. Thalassemia means a decreased ability to make particular hemoglobin chains. Alpha thalassemia means I don't make alpha chains. Beta thalassemia, I don't make beta chains. It's extremely common, and that is because most of them are simply traits. They are heterozygotes, and they're asymptomatic. It's the most common cause of a lifelong microcytosis. Most of them are asymptomatic. You simply can't distinguish the causes of microcytic anemia based on the symptoms. Impossible. You have to have a suggestion for the history, or you'll never figure it out. You can figure it out once you get lab tests, but surely not from just the knowing that there's a microcytic anemia. Well, how do you answer the question, what's the most likely diagnosis for anemia? Well, here we go. If there is in the history blood loss, such as GI bleeding, the most likely diagnosis is iron deficiency. And that also would mean things like menstruation, as a second cause of blood loss. Now, cancer or chronic infection gives anemia chronic disease, and the classic is rheumatoid arthritis. Now, part of the same idiopathic disorder, rheumatoid arthritis, I mean, the whole disorder is idiopathic, but the same antibodies, the same autoantibodies are going to damage the bone marrow and you stop making cells. Alcoholics can have just a macrocytosis, but they can also have a microcytosis from sideroblastic anemia. And the most common cause of very small cells, but being asymptomatic, is thalassemia. They have very small cells, but you don't feel symptoms because the body increases the cell count. It's like a tachycardia. You go down in size, so you increase the number. The peripheral smear is not useful. They're all hypochromic. They all can be associated with target cells. The unique finding on iron studies, the unique finding on iron studies is the best initial test to determine the specific cause of microcytosis. Ooh, what a cute picture of target cells. Why, they look like a target. That's right. This is extramembrane bunched up in the center. This is like a size 2 cell wearing a size 15 membrane. It just bunches up in there because it's extra floppy membrane. Now, although it is most commonly with thalassemia, you can get it with any form of microcytic anemia. The unique features and diagnosis of iron studies are that you see a low ferritin, and only one thing gives a low ferritin. The only thing that gives a low ferritin is iron deficiency anemia, nothing else. Now, unfortunately, not everybody has a low ferritin because the ferritin level is an acute phase reactant, meaning that a normal ferritin, or low normal, I should say to be precise, can be present when you have iron deficiency. But when the low ferritin is there, you automatically know you have iron deficiency. There's only one thing that gives a high circulating iron. The only thing with a high circulating iron is sideroblastic anemia. And the only thing that's microcytic with normal iron studies is thalassemia. In iron deficiency, a low ferritin equals iron deficiency. Period. Done. Finished. However, 1/3 of patients with iron deficiency have a normal or even increased ferritin because it's acute phase reactant, a white countosedrate C-reactive protein ferritin in transcobalamin. This means any infection or inflammation can artificially raise the ferritin level. Now, although the only thing that gives a high iron level, circulating iron, is sideroblastic anemia, both iron deficiency and anemia of chronic disease are associated with a low serum iron. So that won't help you answer the question. Iron deficiency increases the total iron binding capacity. Now, this is indispensably important. The TIBC is a measure of the unbound sites on transferrin. It's the unoccupied sites. It's the open sites on transferrin. So if you have open sites on transferrin, you have an increased capacity or high number of unbound sites. If all the chairs are filled, then there's no capacity. If all the chairs are empty, there's a high capacity. In iron deficiency, you got a high capacity because you are empty. Now, the anemia of chronic disease has a low serum iron, low in circulation, but it's trapped in storage. The ferritin, the stored iron, is elevated or normal. This is the circulating iron that's decreased, the circulating amount. The major difference is the iron binding capacity is low. The capacity is low because you're packed up with iron, man. So you have no capacity. You can't fit any in. Sideroblastic anemia has a unique increase in the circulating iron level, and that's because it's all packed up inside the mitochondria in circulation. That's one thing. And thalassemia is a genetic disease that by definition has normal iron studies. Iron deficiency gives you an increased red cell distribution of width. Now, the red cell distribution of width, the RDW, is a measure of whether the cells are the same or different in size. Are they the same or different? It doesn't tell you whether they're big or small, it just tells you whether they're the same or not. It's rather like standard deviation. Standard deviation doesn't tell you the score, it just tells you are they bunched up. So in iron deficiency anemia, are the new cells bigger or the new cells smaller? Well, in iron deficiency anemia, the new cells are smaller. Newer cells are more deficient than iron, so they're smaller. Now, normally, new cells are bigger because reticulocytes are bigger. So the most common wrong answer is saying new cells are bigger. Yeah, that's true in a normal person, but not if you're iron deficient. If you're iron deficient, as the body runs out of iron, newer cells have smaller amounts of hemoglobin. Less hemoglobin, they get progressively smaller. We're running out of food, we make smaller sandwiches. there's an elevated platelet count. It's very common, and that's a tested question, ladies and gentlemen. That is a tested question. Hi, this guy has a microcytic anemia. Why is his platelet count up? You are expected to know not to go chasing a cause of a high platelet count. You don't have to go do something. You don't have to go do JAK2 testing looking for essential thrombocythemia. You have to simply know, hey, I understand that iron deficiency anemia gives you an elevated platelet count. I understand it. I don't have to do anything about it. It's fine. It's just part of the disease. We think it's because erythropoietin has some stimulatory effect on megakaryocytes. Now, the single most accurate test is a bone marrow for stainable iron. I never said I was going to do it. I never said I was going to do it. We don't have to do it, but it is the most accurate test. What we do is look at the iron studies. Sideroblastic anemia, the most accurate test is Prussian blue. What a beautiful picture here. It's a picture from my own chief resident, and this is iron built up inside the rings of the mitochondria around a red cell. See, this is not basophilic stippling. Basophilic stippling occurs throughout the entire red cell. Now, ring sideroblasts are specific for sideroblastic anemia. Thalassemias all give normal iron studies, so a normal iron study can't tell you which type of thalassemia you have. The most accurate test to tell you which type of thalassemia you have is the electrophoresis. You have to look at different bands of the hemoglobins. That's the only way to tell. Is this alpha thalassemia or beta thalassemia? It tells you that you have abnormal bands of hemoglobin on the electrophoresis. Electrophoresis is the answer for basically any hemoglobinopathy. For you on step 2, it's the answer for thalassemia and for sickle cell thalassemia and sickle cell electrophoresis. The most accurate test for alpha thalassemia is genetic studies. That's because there's nothing on electrophoresis that can tell you, hey, this is alpha thalassemia for sure. 1 gene deleted is normal. 4 gene deleted, they're dead, so you don't see them. So it really comes down to 2 and 3 gene deleted is what you see. Because it takes 4 genes to make the alpha chain. 4 genes to make the alpha chain. If you're missing 1, it's normal. Missing 4, they're dead. Now 2 and 3 is all that's alive. If you're missing 3 out of the 4 genes and you're having such a tiny number of alpha chains, you form beta-4 tetrads or hemoglobin H. And remember that 3 gene deleted thalassemia, alpha thalassemia, is the only thing that's microcytic. The only microcytic gives you increased reticulocyte count. Only 3 gene deleted alpha thalassemia is a high reticulocyte count. All thalassemias will have a normal RDW because they may be small cells, but they're all small. Let's review the difference between these. With alpha thalassemia, with 1 of the 4 genes missing, you are normal, completely normal. Whereas beta thalassemia trait, you'll have an increased fetal and an increased A2 because you have decrease in the hemoglobin A, but an increase in the fetal in the A2. 2 genes deleted, you'll have a mild anemia, but a normal electrophoresis. You can't find it. You can't find it because there's alpha chains in all the hemoglobins. Now, this concept of 2 gene deleted doesn't apply to beta thalassemia because beta chain only has 2 genes, Now, when there's 3 gene deleted, you have moderate anemia and beta-4 tetrads, known as hemoglobin H. It's the only one with increased reticulocyte count. There is a beta thalassemia intermedia, and that's a good name because it tells you, well, it's got a normal hemoglobin F, and there's no transfusion dependence. 4 gene deleted, you're dead. That's gamma-4 tetrads or hemoglobin Barts, and they die in utero. This concept does not exist for beta thalassemia. Now, the reason we emphasize diagnostic testing so much in hematology is because what do you think they're going to ask you about on your test? They're going to ask you like, hey, what do you treat iron deficiency with? What do you treat folate deficiency with? No. Yeah, iron deficient replaced with iron, oral ferrous sulfate. And if it's not enough, it's insufficient. In other words, if oral therapy is insufficient, you get intramuscular iron. Now, because the majority of iron given orally is not absorbed, you should be telling people, hey, your stool will turn black. Well, how are you on the test supposed to distinguish between the black stool of bleeding and the black stool of ferrous sulfate replacement? Well, ferrous sulfate replacement makes you constipated, and bleeding gives you diarrhea. Ferrous sulfate makes you constipated. Bleeding gives you diarrhea. The other thing is ferrous sulfate won't make the stool guaiac positive. Stool guaiacs only become positive with heme iron. That basically means hemoglobin, myoglobin, hemoglobin, myoglobin. And you won't get the black stool of iron replacement to make the heme card positive. In the anemia of chronic disease, there's nothing to do except correct the underlying disease. Erythropoietin will only work with end-stage renal disease. Only end-stage renal failure responds to erythropoietin. In sideroblastic anemia, you have to correct the underlying cause, like alcohol. That's the biggie. Got to make them stop drinking. You can't get around their alcoholism. And a small, rare number will respond to pyridoxine, because a small, rare number are from pyridoxine deficiency or pyridoxine developmental defect. For thalassemia, there is no specific therapy for trait. Don't build up recessives. For beta thalassemia major or Cooley's anemia, well, we have to transfuse those kids every 1 to 2 weeks for their entire life. Actually, for chronic transfusion is the only way to fix it. You have to transfuse them for their entire life. And that's why iron overload is managed with D-ferrosirox. D-ferrosirox is one of the oral iron chelators. Deferoxamine given by subcutaneous injection. Deferoxamine is given by subcutaneous injection. But Cooley's anemia or beta thalassemia major will give you iron overload because you have a milligram of iron in every milliliter of packed cells. Now, since you only need 1 to 2 milligrams a day, and you get a milligram per milliliter, if you get 2 units of packed cells, you just got 2 years worth of iron. Wow, no wonder it builds up if you do this for 5 or 10 years.